Hello friends, so this is lecture number 2 of the chapter Epidemiology of Communicable Diseases, and today we are going to learn about enteric fever. We will discuss about its causative factor, host factor and environmental factors along with the diagnosis and management. I have already uploaded videos on topics like ASHA, ICDS, PHC and many more. You can check them out, the link is given in the description section below. So let's get started. Typhoid is a systemic infection mainly caused by Salmonella typhi, a bacteria that is found only in humans. It is often said that typhoid acts as a barometer of country's sanitation. The term enteric fever includes both typhoid and paratyphoid fevers. Typhoid is endemic in India. Endemic refers to the constant presence of disease or infectious agent within a given geographic area or population group without importation from outside. It may also refers to the usual or expected frequency of disease within such area or population group. Now let us see the epidemiological determinants. Now let us first talk about the agent factors. The causative organism is Salmonella typhi, which is a gram-negative bacilli belonging to the Enterobacteriaceae family. It has three important antigens O, H and Vi. The bacteria can survive inside the body cell. It is however easily killed by drying, pasteurization and common disinfectant. Other species like Salmonella paratyphi A and B can also cause similar illness but are less common. The primary sources of infection are feces and urine of cases or carrier. The secondary sources are contaminated water, food, finger and flies. The incubation period is from 10 to 14 days. It may extend up to 3 weeks. The reservoir of infections are cases and carriers. Cases can be mild, mild and severe, whereas carriers can be convalescent or chronic carrier. There are other types also like fecal carrier or urinary carriers. So carriers are person carrying the pathogen without showing any signs and symptom. Now they are more important than cases as they continue to spread the disease unknowingly. The carrier stage is more common in the middle age person and female. So talking about the host factor, typhoid is most common in children and adolescents between 5 and 19 years of age. Males are generally affected more often while females tend to become carrier more easily. The body's cell immunity plays an important role in protection. People who have higher gastric acidity or stronger intestinal immunity are usually more resistant to infection. Now let us see the environmental factors. Now typhoid can be seen throughout the year, but it peaks between July and September, that is during the monsoon season when water contamination is more likely. The bacteria can survive in the environment for quite some time, about 48 hours in water, a month in ice or ice cream, up to 70 days in sewage contaminated soil. They can also grow rapidly in milk without changing its taste or appearance, and vegetable wash with contaminated water can also easily spread the disease. Poor sanitation, open defecation, polluted water supplies all contribute to its spread. The mode of transmission is usually feco-oral, meaning it spread through ingestion of contaminated food or water. It can spread directly through soiled hands or indirectly through contaminated water, milk, food or flies. So when it comes to clinical features, adults usually have a gradual insidious onset of illness, whereas children often have an abrupt onset with chills and high-grade fever. The fever typically rises in a step ladder pattern. In the early or prodromal stage, the patient may have malaise, headache, abdominal pain and constipation, and as the disease progresses, there may be splenomegaly, abdominal distension, tenderness and a characteristic relative bradycardia. A dicrotic pulse may also be seen. If it is not treated properly, it can result into serious complications such as intestinal hemorrhage, perforation, urinary retention, pneumonia, thrombophlebitis and myocarditis. The case fatality rate is about 1 to 4%, but it can be 10 times higher in children under 4 years of age. If untreated, go up to 10 to 20%. For diagnosis, the gold standard is blood culture, where Salmonella typhi can be isolated from blood, bone marrow or stool. The Vidal test is also commonly used. Vidal test detects antibodies against the O and H antigen. The O antibody, it appears around 6th day and H antibody appears by 10th to 12th day of illness. There are also rapid diagnostic tests like IDL Tubex test, which detects the IgM antibodies within minutes, and Typhoid, which detects both IgM and IgG antibodies. So for the treatment of carriers, intensive treatment with ampicillin or amoxicillin together with probenecid for 6 weeks is given. These drugs concentrate in the bile and achieve eradication of the carrier state in 70% of the carriers. Second is surgery. Cholecystectomy with concomitant ampicillin is most successful approach. The carrier should be kept under surveillance. They should be prevented from handling food, milk, water for others. Health education should be given regarding washing of hands with soap after defecation or urination and before preparing food. So now let us talk about the control of typhoid. There are three main steps. The first is control of reservoir, second is interrupting transmission, third is protection of the susceptibles. So for cases, early diagnosis is very important. Once the case is detected, it should be notified whenever it is required by the law. The patient needs to be isolated until we get 3 stool and urine samples taken on different days that all comes back negative. The treatment is done with fluoroquinolones, which are the drug of choice. Patient's stool and urine should be disinfected with 5% cresol for at least 2 hours. The soiled clothes and bed linens are soaked in 2% chlorine and then steam sterilized. After the patient recovers, we still do follow-up stool and urine test for after 3 to 4 months and again after 12 months to ensure that they are not carriers. Now about carriers, we need to first identify them through serological and culture test. They are treated with amoxicillin or ampicillin along with probenecid. Sometimes if the bacteria are harbored in the gallbladder, cholecystectomy is needed. Carriers should always be under surveillance and strictly not allowed to handle food, milk, water. Now the second major step is interrupting transmission, which mainly means improving sanitation. This involves protecting and purifying drinking water supplies, improving basic sanitation, promoting food hygiene like safe cooking, clean storage, and personal cleanliness among food handlers. Now, the third step is protecting susceptibles through immunization. Vaccination is recommended for people living in endemic areas, household contact of patient, school children, hospital staff, travelers to endemic region, and even people attending large gatherings like melas or yatras. The two main vaccines are: the first is subunit polysaccharide vaccine. It is given one subcutaneous dose to people aged 2 years and above and revaccinated every 3 years. The second is the live attenuated TY21A vaccine. Now this one is given orally as 3 doses on day 1, 3 and 5 for those aged 5 years and above. This too is repeated every 3 years. So with this we have come to an end of this lecture. If you found this video helpful, like the video, share it with others and subscribe for more.